Just a quick message from our sponsor. Like most of us, when I first heard about the DEA MATE requirement of 8 hours of training, my first reaction was like, great, just another hoop to jump through. But then I learned about the Pain Management and Opioids Adaptive Learning Program from NEJM Group. It's free, and it's actually turned that requirement into something engaging and useful. The course is interactive, 62 case-based questions, videos, infographics that walk you through the complexities of pain management, opioid prescribing, and substance use. You walk away not just by being compliant with requirements, but sharper for your patients. You earn 10.25 CME credits along with it and ABIM MOC points. So if you have to spend the time, why not make it count? You can check it out, and we'll link it in our show notes at cme-info.nejm.org/core-IM. And with that, let's get back to the episode.
Welcome to Beyond Journal Club, a collaboration between CoreIM and NEJM Group.
The goal of Beyond Journal Club is to take landmark clinical trials and put them into context, telling the story of how we got to where we are and what it means to take care of our patients. I'm Dr. Shreya Trivedi. I'm an internist at BIDMC.
I'm Dr. Greg Katz, cardiologist at NYU.
And I'm Dr. Clem Lee, a MedPeds hospitalist in Boston and a guest editor at NEJM.
I'm Dr. Lakshmi Ravindra, endocrinologist and NEJM editorial fellow. Today, we're diving into the rapidly changing world of diabetes to look at the QWINT-1 trial. This investigated once-weekly insulin efsitora in people with type 2 diabetes and was published in the New England Journal of Medicine in June of 2025.
And before getting into the QWINT-1 trial,
we'll review different types of insulin we have available and when we should be reaching for insulin in the first place.
And then finally, we'll dive into the QWINT-1 trial and talk about how once-weekly insulin may fit into our landscape of diabetic treatment options. So I feel like I need to come clean because all of these insulin options honestly make me feel like I don't know anything about endocrinology at all. It's really confusing. Short-acting, long-acting, rapid-acting, intermediate-acting, they all have different brand names. Learning insulin treatment is like learning a second foreign language on top of medical jargon.
Yeah, Greg, maybe we should be making a Duolingo for insulins.
Yeah, that very much resonates. And I think it's worthwhile to go through the different types of insulin we have available. And this will really prime us for the discussion we're going to have after the QWINT-1 trial.
So most people will recognize the long-acting or basal insulins. We have two big options here, glargine, also known as Lantus, and degludec, also known as Tresiba. They take a couple of hours to start working, but once they do, they can lower the glucose for 24 hours or even longer.
Next up, we have our mealtime or correctional insulin, and we typically think about this as a rapid-acting insulin. This includes our insulin Lispro and Aspart, and if it's helpful, you can use a mnemonic of the fast-moving city of LA to stand for Lispro and Aspart. Unlike the basal insulins, they're really quick on. They act in about 15 minutes, peak in 1 to 2 hours, and last for a total of 2 to 4 hours until your next meal.
Yeah. And then the brand names for these rapid-acting insulins are going to end with log. So you might see insulin Lispro called Humalog or the insulin Aspart called Novolog. And so if you see an insulin that ends with a log, think about it acting fast and ending fast.
All right, so here is where things can start to get fuzzy for people. There's also a short-acting insulin called regular insulin. It's the old-school short-acting insulin before the newer Lispro and Aspart came onto the scene. The regular insulin takes a bit longer to kick in, about 30 minutes, so it needs to be given before meals, and it lasts around 6 to 8 hours.
Then we're going to go to our intermediate-acting NPH as a basal-ish insulin. So it's going to act or work for about 12 to 18 hours, but it has a peak, and this happens about 4 to 8 hours after the injection. The most common reason you're going to be seeing people reach for this insulin is when cost is an issue. NPH is a lot cheaper, and this is typically because it's an older formulation. It's also great for treatment of glucocorticoid-induced hyperglycemia because the peak of NPH lines up with the morning peak of prednisone.
And then you might see the brand name for NPH as Humulin N or Novolin N. So one way to remember it is if it's with an N, think of NPH, and the intermediate, right? That's the intermediate one that is 12 to 18 hours of insulin duration.
And last up, and one that gets people a little bit confused, is our mixed insulin. And you might see this in somebody's medication list as 70-30 or 75-25. And so this is when we combine NPH with a short-acting insulin. For example, 70-30 is 70% NPH and 30% regular insulin.
Yeah, this does trip me up. Like, and also just the why, right? Like, why is somebody on 70/30 instead of like the typical basal bolus, right?
So mixed insulins like 70/30 are really helpful in a patient who might be overwhelmed with a complex insulin regimen or might not be able to give themselves multiple injections a day. So rather than needing 3 to 4 injections a day, like a basal bolus regimen would make you have, you can give a twice daily dosing of 70/30 because you'll get some basal coverage and some mealtime coverage. So you're going to have fewer injections in the day, but you're going to lose your ability to fine tune the doses as much. And you're going to have a more hypoglycemia risk because if somebody skips meals, they've taken the insulin already that's going to cover a meal that they might not eat. So those are all just things to keep in mind.
Okay, that was a really helpful review for me, and I hope for our listeners too. And so to recap, there's 4 major pharmacokinetic profiles of insulin: rapid acting, short acting, intermediate acting, and long acting. The rapid acting ones, Lispro and Aspart, and the short acting one, which is regular, are generally considered prandial or correctional insulins. Intermediate, NPH, and long acting insulins are considered basal insulins.
Yeah. And then there's also the mixed insulin, right? The 70/30, which is NPH plus a short acting or rapid acting insulin.
Yeah, and over the years, one way I've simplified the duration of actions for myself is by using a mnemonic of perfect squares. And so I'll just recap that here. The rapid acting ones last about 4 hours. That's 2 squared. Regular insulin lasts around 9 hours. So that's 3 squared. NPH lasts around 16 hours. That's 4 squared. Glargine lasts around 25 hours, 5 squared. And degludec lasts around 36 hours, which is 6 squared. These are obviously rough estimates, but I'm hoping that that's a helpful mnemonic for you.
Okay, so now we've reviewed the current types of insulins, and we might have more insulin options in the horizon. What are the current guidelines for when we should reach for insulin for a patient with type 2 diabetes?
Yeah, so as my colleagues and I like to joke about, you ask 4 different endocrinologists, you might get 4 different answers. I think different providers are going to have their own process for insulin initiation. But if we go more with the guidelines, according to the American Diabetes Association or the ADA, for treatment of type 2 diabetes, the initiation of insulin should be considered in 2 big picture scenarios. The first one is if a patient has symptoms of hyperglycemia. So these could include polyuria or polydipsia, and this is regardless of their previous medications that they were on for their diabetes. The second big scenario is if their hemoglobin A1C or blood sugar levels are very high. For example, an A1C of above 10 is typically the threshold cutoff, and according to the guidelines, that's the threshold, or a blood glucose level of above 300 milligrams per deciliter.
And I think it's really important that you have a good mental model for prescribing insulin because once you put somebody on it, it is this massive change for a patient's life.
Yeah, it's a really great point, Greg. I mean, with insulin, you are signing up a patient to prick their finger at least once a day, if not more, if they don't have a continuous glucose monitor. And then they have to proceed to stab themselves with a pen needle or a syringe to give themselves their insulin. And this might happen multiple times a day as well.
Yeah, definitely. It's one thing to see that insulin in a patient's chart, but then it's another thing to ask the patient, how's it going taking that insulin and seeing the different types of answers you might get. And I remember recently having this patient with early dementia, and she was on that, the basal bolus, kind of long acting mealtime insulin, living alone. And not surprisingly, with her memory issues, giving herself insulin became really hard. Her A1C jumped from 7 to 9.8. And I think that situation, and I think so many other patients I've had, I've kind of just been like, I wish I had more options.
Yeah, and you're in luck because now we have another option. That's a great segue to jump into QWINT-1 trial to discuss a new weekly insulin and how that might benefit our patients, and specifically the patient that you just mentioned, Shreya.
Just a quick word from our sponsor. With a cold winter, it can feel so easy to be in the dumps, especially with being sick here and there like I am right now. And one small thing that's helped me this season is cooking. The Caraway cookware has made it much easier and very doable. Really like leaning into cozy meals like soup, simple one-pan dinners, without the inertia energy. I think for me, like knowing that the ceramic surface is naturally slick, like I've never seen anything else like this. I don't have to put much oil. The cleanup is really so quick. And there's also a peace of mind to it too. Caraway cookware is designed without those forever chemicals. And there's a reason that over 100,000 people have rated Caraway Kitchen 5 stars. And the thoughtful details help. For example, there are glass lids so I can keep an eye on things, or a kitchen timer that works without wet hands. Caraway cookware set is a favorite for a reason, and you can actually save up to $190 versus buying the items individually. And if you visit carawayhome.com/CoreIM, you can get an additional 10% off your next purchase. And this is exclusive to our listeners. So visit carawayhome.com/CoreIM or use the code CoreIM at the checkout. Caraway, non-toxic kitchenware made modern. And with that, let's get back to the episode. All right, team, let's talk about the shiny new thing, a once weekly basal insulin. Sounds great, but what is the data?
Important question, Shreya. So the QWINT-1 trial compared insulin efsitora, or once weekly insulin, to our good old insulin glargine, which is taken daily. The researchers in the QWINT-1 trial asked if once weekly insulin efsitora would be non-inferior to insulin glargine, and this was measured as the change in hemoglobin A1C after 1 year of treatment.
So they randomized 795 patients 1-to-1 to either daily glargine or weekly efsitora. There were about 400 in each group, and the trial was open label, so patients knew exactly what they got.
And then who were these patients in the trial?
Yeah, picture your kind of typical patient here in studies, mid-50s, has had type 2 diabetes for about 9 years, BMI of about 32, and then living in the US, Argentina, or Mexico. And this is where the study sites were.
Half of the patients were women, about 70% were white, and their starting A1C was about 8.2%.
Yeah, that makes me think like these were not the patients who were, A1C of 11, we're out of options kind of patient.
It's totally true. And about half of these patients were on just one non-insulin diabetes medication, and the other half were on 2 non-insulin diabetes medications. Almost 94% were on metformin, and only 10% of these patients were on GLP-1 agonists.
So just to reiterate, in this trial, we're seeing insulin being initiated in a population with relatively early and less severe type 2 diabetes.
Yeah. And then this was a treat to target RCT, right? So let's go over what that means and how they dose the insulin. If we start with the efsitora group, that once weekly insulin, everyone began at 100 units of insulin a week with an autoinjector.
Then, every 4 weeks, if the fasting glucose was still high, they would step up the doses. So from 100 to 150 units, and then further to 250, and finally to 400 units weekly.
And if the patient hit 400 and still wasn't a goal, you could even go higher. And ultimately, 71 out of 400 participants were paced on more than 400 units per week.
And when they were determining dose changes, these were based on the median of the previous 3 fasting blood glucose levels. They were targeting a blood glucose level of 80 to 130.
Yeah. And then here's a twist. If a patient in the efsitora arm became hypoglycemic and needed a dose reduction, they couldn't go back up again for the rest of the trial.
Yeah, and that's important because real life doesn't always work that way. In practice, we often have the patients try titrating up again with some careful monitoring.
And then for the glargine dosing, patients started at 10 units daily and were adjusted every few days to hit that same fasting target of 80 to 130.
And, in trials, we typically have some dropouts. In this scenario, the dropouts were basically the same, about 11% in both arms. So no big red flags there.
Yeah. And this was a non-inferiority trial, right? So the study goal was to see if efsitora lowered A1C just as well as glargine at 52 weeks.
And as a brief review of non-inferiority trials, this is where we test whether the experimental treatment, and in this case, that's insulin efsitora, is not less efficacious than an active control treatment that's already being used. And in this case, that's daily insulin glargine. So in terms of the QWINT-1 trial, efsitora would be accepted as non-inferior to glargine if it led to a hemoglobin A1C difference of no greater than 0.4%.
So they also looked at fasting glucose, insulin dose, well-being, and of course, they checked for hypoglycemia.
All right, I think that's enough for the setup. So Lakshmi, will you do the honors of telling us the trial results?
How gracious of you, Clem. I would love to. So with efsitora, the A1C dropped from 8.2% to 7.1%. And in the glargine arm, it dropped from 8.3% to 7.1%.
So nearly identical.
Yeah. Also, we know that Efsitora was non-inferior, but it was not superior to glargine. In this scenario, the p-value was 0.68.
And for that secondary outcome of getting the A1C under 7%, 57% of patients in the Efsitora group and 52% of patients in the glargine group, which was not statistically different.
And then looking at the change in the fasting blood glucose in 1 year, it was about 127 milligrams per deciliter in both groups. So the change from the start of the trial was not different. And then again, we have a tie game.
When we look at the hypoglycemia, that is where things start to get interesting. But to step back a little bit, the ADA describes 3 levels of hypoglycemia.
So level 3 hypoglycemia, which is any level of hypoglycemia that requires assistance from another person, usually due to a neurologic compromise like syncope or a seizure. In this study, there was 1 episode of that in each group, so it was pretty rare.
But the combined level 3 and level 2 hypoglycemia, which is defined as a glucose of less than 54 milligrams per deciliter, was 43% lower with insulin Efsitora when compared with insulin glargine, which is really huge.
Yeah, 4 people in the glargine group had more than 10 of these combined level 2, level 3 events, and in the Efsitora group, nobody did.
That is so interesting that we can give a medicine just once a week and almost no one gets severely hypoglycemic. It seems so imprecise and it works.
It's kind of amazing. Another thing that I was struck by here is how much insulin these patients required. So the glargine group needed about 333 units a week, and the Efsitora group about 289 units per week. And so this is a group of people who were not on insulin to begin with. I mean, they were 8, not 10, but their insulin got escalated to like 40 units per day. And so even if these patients were not classically hyperglycemic, to me, these are very chronically ill people who have really severe insulin resistance.
Greg, I'm so glad you pointed that out because I guess it's humbling to think about maybe the amount of insulin resistance that we might not be able to appreciate and how much insulin one might actually need to get those sugars in the 80s to 130s range that we all aim for.
All right, so bringing us back, what's the takeaway here?
All right, thanks, Clem. So big takeaway. Efsitora, a once-weekly insulin, it works. It was similar at lowering the hemoglobin A1C when compared with daily insulin glargine.
And even though it's not better than glargine for glucose control, it might be better than glargine for reducing hypoglycemia.
All of that being said, just quick reminder that these patients were people with A1Cs around 8, mostly just on 1 to 2 medications, not acutely ill, and in the outpatient setting. Most of these things are not making me think of individuals or patients that we would be worried about hypoglycemia on a daily basis for.
Yeah, definitely, right? Not the patient that we're like struggling with treatment options before we reach for insulin.
Exactly, Shreya. And there's a whole other set of QWINT trials that ask a lot of other questions about once weekly and insulin Efsitora, from comparing it to degludec to looking at people already on insulin. And without getting into details, there's a general overall sense that once weekly insulin Efsitora is able to hold up across other type 2 diabetes populations.
So this all sounds great, but let's call out the elephant in the room. Efsitora is not yet FDA approved.
Yeah, definitely a fair thing to call out. And I think if this does get approval and is available for patients, I'm curious about a very practical elephant in the room, right? We're doing all this and thinking about this from the like very patient-centered perspective of like, how do we minimize injection burden? But I guess, how do we reconcile a weekly long-acting insulin for patients that we might see? For example, that lady I was talking about with dementia, giving 4 or 5 injections of insulin every day, getting agitated, it just isn't going to make sense for her. And with these patients, yeah, maybe you can max out the glargine, but you still find their finger sticks, pre-meal are still in the 250s in the hospital. I guess what I'm trying to ask here is, how does this long-acting weekly insulin work for a patient like this, right? Would it actually help minimize the injection burden, or would a patient like this still need mealtime coverage? And maybe another way to think about it is like, which diabetic patient population will this weekly insulin really help?
Great question, Shreya. And I think to really address this, we need to go back into the pathophysiology of type 2 diabetes, everybody's favorite thing. So the earliest abnormality I think we tend to see in type 2 diabetes is insulin resistance. The pancreas is able to make insulin, but the cells in the body aren't listening to the insulin and they're not opening the doors to allow glucose out of the bloodstream and into cells.
And things get even more complicated when we think about what's happening in the liver. And so the liver basically has this faucet that is continuously making glucose and putting it into circulation for the rest of the body to use. A second role of insulin is that when it works and the body listens to it, it turns off this faucet and it stops the liver from producing glucose and putting it into the bloodstream.
We're definitely oversimplifying here, but it's really helpful to understand that when the body has insulin resistant presence, glucose isn't able to get into organs, but the faucet continues to drip glucose out of the liver. And both of these scenarios are continuing to worsen hyperglycemia.
And then to worsen things, the more and more hyperglycemia there is, as hyperglycemia is toxic to the pancreas, the more and more that beta cells are being hurt and lost. And eventually we reach a state where the beta cells are so damaged that the pancreas can't even make insulin anymore. And this is when we transition from insulin resistance to insulin deficiency.
And so to get back to your question, Shreya, that patient you described probably had fairly late stage diabetes. And so in the earlier stages, people can sometimes get away with just basal insulin. But once you have progressive insulin resistance and progressive relative insulin deficiency, it's pretty likely that patients are going to need mealtime insulin coverage as well.
Yeah, I see. So I guess if Estor does get approved, we might have some patients on it, but yeah, in one sense, they might have fewer injections from the perspective. They don't have to do that daily basal insulin. But for these late stage diabetes patients, they might still need that mealtime insulin injection.
Yeah, so for those patients, we might still need to use mealtime aspart or Lispro. So Shreya, it sounds like you tried to max out glargine for your patient, but it was a challenge. And I feel like this is something we see pretty commonly.
Yeah, definitely. And the other thing I was thinking about in the sense of minimizing injection burden was maybe tapping into some of the oral options, right? And especially as Lakshmi and Greg mentioned, there's the insulin resistance physiology part of it, and there's also the relative insulin deficiency. And so it made me think also about what are the oral options I can give her to minimize the injection burden for her.
Yeah, I think it is really important for us to talk about what oral options we have on the table. And so this trial was looking at patients who had nowhere near to maxing out their oral medications. Remember, average patient from this trial, A1C of 8 on metformin and maybe one oral medication. And so, like, Lakshmi, correct me if I'm wrong, but is there a world where any endocrinologist takes a patient like this and puts them immediately on insulin, right? A1C of 8 just on metformin. There's no way you're going for insulin next, right?
Yeah, unless there's something we're really missing, it's very unlikely to be my first choice in this scenario.
And so then how do you think about what to do next for a patient? A1C of 8, one oral hyperglycemic medicine, and we need to do a little bit better when it comes to glucose control.
We have so many other oral options. Some are older, some are newer, but practically speaking, the older options that we have are cheaper and more accessible, and in a lot of scenarios, the easiest to add. We've already covered SGLT2 inhibitors, GLP-1, GLP, GIP, combination medications in other episodes, like the diabetes debate episodes. So maybe we'll get into some of the other oral diabetes medications here. To start us off, we have our secretagogues, think glipizide, glimepiride, or repaglinide. These carry a higher risk of hypoglycemia, so they are a little bit riskier, especially in elderly individuals or those that maybe don't have great access to food.
And so most of the patients in this study were on metformin, which helps with turning off that faucet in the liver and reducing hepatic gluconeogenesis. And metformin also improves insulin sensitivity a little bit.
Yeah, so for that patient with the only very slightly elevated mealtime blood glucose levels, metformin can be a really great option.
Next, we have the DPP4s, or if you prefer to use their Christian name, dipeptidyl peptidase 4 inhibitors, also come to mind. These are also called gliptins, like sitagliptin, or the trade name Januvia.
DPP4s are really great for postprandial hyperglycemia. They are typically really safe in the elderly and also those with chronic kidney disease or CKD. They have a really low risk of hypoglycemia because it's only when there's a glucose load, like a meal, that DPP4 is able to stimulate the natural action of the incretin hormones like GLP-1. Again, this is an oversimplification, but just to explain why there's a lower risk of hypoglycemia in patients with this.
Yeah, I love that pathophys. Like, you don't have to worry if a patient's NPO or not. You can just feel comfortable that DPP-4 is just going to work only when there's a glucose load. Yeah, and actually I remember doing an episode on inpatient diabetes meds, and the endocrinologist, Dr. Umpieres, I think he was from Emory, he basically said he tries to get everyone on the surgical units on 0.2 units per kg of long-acting insulin, and then just a DPP-4 to help with a mealtime spike. And that was like, oh, that was such a good case for it.
Yeah, I mean, clearly me and other endocrinologists really like using DPP-4s, but something that we've also noticed is that unfortunately they're not covered by insurance a lot of the time, which is just something to be aware of.
Yeah, that's a bummer. So I guess speaking of drugs that are then on the cheaper side, I also remember learning about the TZDs, right? The thiazolidinediones as an oral option that helps with that insulin resistance and improves the sensitivity to insulin.
Yeah, so next up are TZDs, also known as the insulin sensitizers, as you mentioned, Shreya. Unfortunately, some of their more negative side effects are weight gain and fluid retention, so they're not reached for as much. But the flip side to them is that some of them may also help with fatty liver or MASL D.
These drugs got a really bad rap because of rosiglitazone, which was Avandia. It was found to cause heart failure, and it's why that drug got pulled from the market. But now they're probably at least a little bit underutilized, partly because they cause weight gain. But pioglitazone is cheap, available, and it's an option for some of our patients to improve insulin resistance.
Yeah, totally fair. So it sounds like we have some different oral options we can reach for in the right patient where you want to try to optimize those oral options. And so in terms of my patient where I was trying to minimize the injection burden for her, I did actually go back to using things like metformin and DPP-4, which, sometimes when you think somebody's on insulin, you're like, oh, like I can't go back to square one, but it was actually helpful for her to get her sugars better and not being in like the 250s all day and just thinking about it from a patient-friendly perspective. What can I do to minimize her agitation?
And so all of this discussion about oral medication options makes me wonder, how relevant is this once weekly injection for a patient with an A1C of 8 who's on 1 to 2 medications? And so we don't know what this is going to be like in the actual practical patient who we're going to be starting insulin on, because the phenotype in this trial, on table 1 of this trial, is very, very different than the phenotype of the patient who normally gets prescribed insulin. And so the cynical part of me wonders, like, should we be cheerleading this result because of how far away the patients in this study were from the patients in real life who would actually be getting started on insulin treatment? And so does QWINT-1 tell us anything about how insulin efsitora will work for patients in the real world? Because that's not who was included in this study.
Yeah, definitely. Maybe it'll make us rethink kind of when we reach for insulin and how much insulin our patients might actually benefit from to get actual, glucose control if we're really reaching for something less than 130. So I also think it's fair to end the episode with a bit of gratitude, right? And an appreciation for how far we've come. Yes, we don't have clear details yet on which population in the diabetes world is really going to benefit from this once weekly insulin. And yeah, we still have some work to do when it comes to minimizing injection burden. But, back in the day, we used to have to grind up pancreases from animals to extract insulin, right? And look at where we are now.
And selfishly, I'm also glad that doctors are no longer required to taste or smell patients' urines to detect ketones for diabetes.
Oh,
Surprised to hear you say that.
Yeah, glad that wasn't part of fellowship.
And with that, it's a wrap.
If you found this episode helpful, please share with your team and colleagues and give us a rating on Apple Podcasts or whatever podcast app you use. It really does help people find us.
Thank you to Dr. Jimin Wong for the accompanying graphic.
If you have any feedback, please email us at hello@CoreIMPodcast.com.
Opinions expressed are our own and do not represent the opinions of any affiliated institutions.
Thank you. Take care. Do you want to say that line again, Clem?
Yeah, I don't know if I should say people. I should say patients.
Humans?
Humans, not
Human, not individuals.
Not non-dogs?
That's what my mind was.